Yes, yes.
So I don't know where did we stop last time? Was it I think around the ECAS 3 trial for the TPA? I think that's where it disconnected. So TPA is shown to be effective up to 4.5 hours. It is FDA approved only up to 3 hours. Uh, However, most of the regulatory agencies in the Europe has approved it up until 4.5 hours. Although in US it's not approved till 4.5 hours, but the guidelines, including from American Stroke and American Heart Association, still recommend using it up until 4.5 hours from the time of symptom onset. There is some new data that's coming out where TPA um, was used, I think probably an Australian study, I don't remember, up to 9 hours from the time of symptom onset. Usually in those patients who have wake up strokes. So they go to sleep normally in their normal state of health, and when they wake up, they have stroke symptoms. So the stroke could have started a minute before they woke up or a minute after they went to sleep. And they basically used MRI to make the decision. I think when you come to neuro, you'll learn about different sequences of the MRI, but for stroke, we look at what's called diffusion restriction sequences, which can be positive as early as 15 minutes. However, there is another sequence on the MRI called flare sequence. Those changes take some time to develop, usually 6 hours or more. So people who have diffusion restriction changes, but no flare changes, those are good candidates for TPA, because in that case, stroke probably happened within 4.5 to 6 hour time frame. But if they have diffusion restriction changes and they have flare changes on the MRI, then those are not candidates for TPA, because as I said, flare changes takes some hours to develop. So that's the basic concept. But as I said, there is a PowerPoint of acute stroke treatment. It's the lecture that I had given uh, probably a year and a half, 2 years ago. So you can just go through the exclusion criteria or contraindications for TPA. It also covers which patients are candidates for endovascular intervention or mechanical thrombectomy. Usually patients with large vessel atherosclerosis or large vessel disease. Those are the patients who are candidates for mechanical thrombectomy, not small vessel disease. Of course, you cannot reach those small vessels. Um, I want to focus on the inpatient management of stroke. Let's say, for example, patient got TPA and then got admitted to the hospital, or patient presented outside of the time window of TPA and got admitted to the hospital for further workup. So how do you manage those patients? So the first question is about antiplatelet therapy. I think the most important thing to remember is that antiplatelet therapy, first of all, are used for non-cardioembolic strokes. Non-cardioembolic strokes. Because if you think about cardioembolic etiologies, most of the cardioembolic etiologies, the treatment is usually anticoagulation, not antiplatelet. So for example, paroxysmal AFib, rheumatic valvular disease, left ventricular thrombus, all these conditions are usually treated with anticoagulation. Heparin drip with transition to Coumadin or some newer anticoagulants. So antiplatelets, basically your aspirin, Plavix, are usually used for non-cardioembolic strokes. However, all the patients, like even if it's a cardioembolic stroke, all the patients should get aspirin 325 milligram one-time dose at the time of admission. At the time of admission, okay, all the patients. Usually this is given in the ER. So you guys, when the patients come to the floor, usually don't have to worry about it, but you should just double check. The question is, do you put them for non-cardioembolic strokes? Do you put them on one antiplatelet therapy or dual antiplatelet therapy? Um, that question was answered in two studies. One was a Chinese study that only had Chinese population called Chance trial, and the second one was an international multi-center study called Point trial. Chance trial initially studied addition of clopidogrel to aspirin in two groups of patients. Okay, and Point studied the same thing. They wanted to replicate the results, but in non-Chinese patient population. In two groups of patients, one is what they defined as minor stroke. The second group of patient population is high risk TIA, high risk TIA. If anytime this gets disconnected, just call me or text me on my phone. Anyway, so minor stroke was defined as NIH stroke scale less than or equal to 3. And high risk TIAs were defined as an ABCD2 score more than or equal to 4. I'm not going to cover these scores here, but TIA risk stratification is done by ABCD2 score, where 4 or more is considered high risk TIA. And NIH stroke scale less than or equal to 3 is considered minor stroke. And they found that these patients have better outcomes or reduced risk of recurrent ischemic events, either a recurrent TIA or a stroke, if they were on dual antiplatelet for 21 days. For 21 days. After which, monotherapy, usually with aspirin, can be started or continued, not started, can be continued. Um, the duration in the trial was actually much longer, I think close to 90 days. But they found out that your recurrence risk of ischemic events, if this is your timeline, starts going down. If this is the risk, it starts going down after 21 days. Okay, but your risk of increased bleeding from two drugs remains higher after 21 days. Actually, I shouldn't have drawn it here. I probably should have drawn it. Uh, Here, your risk of bleeding remains higher after 21 days. So that is why the optimal duration is usually 21 days, because the risk of recurrence is usually the highest during that time frame. So the best thing to do usually is when you discharge these patients, you just give them 21 days of worth of clopidogrel. If they've been in the hospital for 5 days, you can just prescribe them 16 days, for example, with no refills. Because many times I see these patients in the clinic after 2-3 months and they're still on dual antiplatelet therapy. So anyways, that's your antiplatelet agents. So what this means for you is whenever patients come into the hospital for a stroke workup with a stroke, you always have to look at the initial NIH stroke scale, which is usually documented in the ER nursing report or ER physician report. And if it is not documented, if the patient comes to the floor, you should ask the nurse on the floor to quickly do an NIH stroke scale, because that will guide your decision to use monotherapy versus dual antiplatelet. We do not use it for larger strokes or NIH stroke scale more than 3 because of risk of bleeding or hemorrhagic conversion. The larger the stroke, the more the risk of hemorrhagic conversion. So that's your antiplatelet. If the patient was already on aspirin before the stroke happened, one question always that gets asked is, after 21 days, let's say patient was already taking aspirin before the admission, after 21 days of dual antiplatelet therapy, do you just continue the aspirin that patient was already taking, or you switch them to Plavix? Some neurologists will switch these patients to Plavix, but usually there is no benefit. There is no strong data to support its use. Besides, aspirin is still not, even with the best outcomes, it is still not supposed to prevent all the strokes, right? I mean, if that was the case, everybody would just take aspirin and nobody would have a stroke. So that simply does not happen. uh, and in terms of efficacy, they are usually not that significantly different. Usually it is a failure to control the risk factors. So if patient has a history of hypertension, their blood pressure usually is running around 150s, 160s, it's not the aspirin that failed, it's failure to control these risk factors. Same thing with diabetes. If their HbA1c is more than what's recommended, it's usually the failure to control those risk factors. Patient's BMI is 35, patient continues to smoke. So you actually have to focus on those, rather than just blindly switching their aspirin to a different medication after 21 days. So that's your question of antiplatelet. By the way, if the patient received TPA, you should not be giving any blood thinners, not even DVT prophylaxis for 24 hours, okay? And then you should get some sort of neuroimaging, preferably an MRI. And once you rule out asymptomatic hemorrhage as a complication of TPA, then after 24 hours, you can start them on blood thinners. Then blood pressure management. Usually in stroke patients who did not receive TPA, we allow for permissive hypertension for 24 hours. And if they receive TPA, we still allow for high blood pressure, but not as high as if they did not receive TPA. So the goal, if patient did not receive TPA, permissive hypertension numbers are 220 over 120. You allow the blood pressure to run as high as 220 over 120 for first 24 hours. And then if patient received TPA, the goal is less than 180 over 105 for first 24 hours. After this, after 24 hours, usually what is recommended is 15% reduction per day of prior day's average, usually. Uh, some people like to take the peak blood pressure and then reduce it by 15%. Some people take average. Either is fine. But the key is that you should not be lowering the blood pressure very aggressively. For example, if a patient presented with a hypertensive emergency, then you would like to lower their blood pressure very aggressively, but not in stroke patients. You are usually more conservative with no more than 15% reduction per day. Okay. So what does this mean? Let's say, for example, if previous days average was 200 systolic, 15% of that is 30. So you should not be reducing it by below 170 the next day. So that's the blood pressure management. Of course, you should always correlate this when you start reducing the blood pressure with patient symptoms. Some patient symptoms may get worse on the very first day you reduce it by 15%, in which case you should just stop doing that, give them a bolus and let it run high for another 24 hours or so. The long-term goal, once the patient is discharged, the outpatient blood pressure goal usually is defined by presence of comorbidities. So if they already have a history of hypertension before the stroke, then blood pressure goal is less than 140 over 90. If they have a history of diabetes with or without hypertension, the goal is less than 130 over 80. If they neither have a history of hypertension or diabetes, the goal is less than 120 over 80. This is your outpatient management. Hypertensive emergency. I always tell people it's a diagnosis of exclusion in the setting of a focal neurological deficit. Okay, patient presented with right-sided weakness and has a blood pressure of 200 over 100. Do not assume that that is the right-sided focal weakness is actually from hypertensive emergency. Almost always it's actually from a stroke, because when patients have acute stroke, usually their blood pressures are high, and that is why we allow the blood pressure to be high, because your brain depends on it, that high blood pressure, to get more perfusion. So without getting an MRI of the brain, do not start lowering their blood pressure aggressively, assuming that it is hypertensive emergency, because if you do so, you may actually expand the infarct, and their symptoms may get worse. So in the setting of a focal neurological deficit, hypertensive emergency is always a diagnosis of exclusion. I've seen 3 or 4 patients like that. Like, actually, ER physicians will assume that right-sided weakness is from high blood pressure, like quote unquote hypertensive emergency, without the MRI. And patients have gotten like 3 doses of labetalol and even like nicardip into it. And then when you get the MRI shows a big stroke, and then patients get worse. So uh, usually avoid doing that. Blood glucose management in the hospital. If the patient is normoglycemic, you should try to maintain normoglycemic. Try to maintain them normoglycemic. But patient is hyperglycemic in the hospital, you should try to maintain their blood glucose between 140 to 180. I believe SHINE trial studied more aggressive lowering of blood glucose. Uh, I don't believe the lower goal they used, I think it was 120 or less, as far as I remember. But don't quote me on that. But anyways, what the SHINE trial study showed, that more aggressive reduction below this point in patients who are hyperglycemic did not provide added benefit, like in terms of morbidity or mortality at a 90-day period. Okay. In fact, the episodes of hypoglycemia were much more frequent in this group. So if the patient is hyperglycemic, 140 to 180 is a reasonable accepted range. Long-term goal for blood glucose on an outpatient basis after stroke is defined by HbA1c goal less than 7%. Just remember that. The problem with all those general guidelines for the blood pressure and HbA1c is that those are not necessarily studied in a subgroup of patients who had a history of prior ischemic stroke. In fact, some of the blood pressure guidelines um, uh, actually intentionally omitted stroke patients. So, your other general guidelines for medicine for blood pressure may not necessarily apply to stroke patients. So for now, you just have to remember these numbers. Everybody should be on a DVT prophylaxis in the hospital, ideally with SCDs, but you can also use pharmacological uh, pharmacological treatment, enoxaparin or subcutaneous heparin. And the combination usually is better than either alone, unless you have a contraindication to use pharmacological treatment, such as within 24 hours of TPA, or if patient has a very large stroke and you are concerned about the risk of bleeding. Um, all the patients should get a statin by the time of discharge, but the earlier you start it, the better it is. I think Sparkle study um, showed that atorvastatin Lipitor 80 milligram reduce the risk of ischemic events over 5 years. But I think they included in the Sparkle trial all the patients who had an ischemic stroke within past 6 months. But I think later studies have shown that if the statins are initiated early on after the stroke, the benefits between the statin group and the non-statin group begin to diverge even before 6 months. So everybody, the JCO guidelines or the Joint Commission guidelines for stroke centers, it's usually all the patients should be on statin by the time of discharge. Usually the goal for LDL is 50% reduction from baseline. But if they have a history of diabetes, you usually want their LDL less than 70. So that's your basic management of stroke patients in the hospital. Cardioembolic strokes, usually, as I said, are treated with anticoagulation. For example, patient has paroxysmal atrial fibrillation, rheumatic valvular disease, left ventricular thrombus. Usually, these conditions are treated with anticoagulation, either heparin drip with transition to coumadin, or you can start them on newer anticoagulants. Um, the most important question in cardioembolic strokes, because they also result in large strokes, because they stop, I don't know if you remember from last time, they stop at that 90-degree turn the vessels make, the embolus, and may sometimes result in a big wedge-shaped infarct. So because of the size of the stroke, the risk of hemorrhagic conversion is very high. And so anticoagulation sometimes may need to be held for 7 days or so if the stroke is large in size without hemorrhagic conversion. If the patient has hemorrhagic conversion of the ischemic infarct, then you should probably wait about 10 to 14 days before starting anticoagulation. However, cardioembolic strokes also present in another way that we covered last time. They may present with multiple infarcts, small infarcts in different vessel territory on two sides. And if they just have small infarcts and patient does not have a lot of deficits, you can basically just start anticoagulation right away. You don't need to wait. However, if they have a big stroke or big infarct on the MRI with severe deficits, you should probably try to avoid it for 1 week to reduce the risk of hemorrhagic conversion. Usually, if you put the patients on anticoagulation in that scenario, we try to avoid the bolus if you are doing the heparin drip, and we usually try to maintain APTT goal between 40 to 60 in most large ischemic stroke patients, instead of a higher APTT goal that you guys use to treat DVTs and PEs. And those patients with DVTs and PEs are usually given heparin bolus, which we try to avoid in stroke patients. So that may be an important point to remember. The exception, of course, for cardioembolic strokes is infective endocarditis, which is usually treated with antibiotics and not with antiplatelets, not with statins, not with anticoagulation. Infective endocarditis is usually treated with antibiotics. Well, there are some patients who may be surgical candidates too for infective endocarditis, but that's beyond the scope of this lecture. I think you can probably just review the guidelines on which patients are candidate for infective endocarditis, like surgery, who have stroke. So you can ask me when you come in the neuro rotation. I think that pretty much concludes the management. One notable exception is anticardiolipin or antiphospholipid syndrome, which was included in under other causes of stroke. Anticardiolipin antibody related strokes are usually treated with a combination of antiplatelet and anticoagulation. This is usually one of the very rare instances in neurology where we like to use both, like for example, a baby aspirin and an anticoagulation. So just remember that this may be the only time where those may be indicated. Management of dissection, which was also one of the other causes of stroke, usually is done with an antiplatelet agent. Most patients are actually not surgical candidates. Rarely, in some patients, we use heparin drip like anticoagulation with transition to coumadin. Usually, if the dissection is large in size, in other words, it is long, not large, it is long in extent, then we like to use anticoagulation. Antiplatelets, however, are usually used if it's a short segment, and if patient is usually asymptomatic without infarct or stroke on the MRI. When I covered the classification of stroke, large vessel, small vessel, cardioembolic, other, and cryptogenic, one thing I forgot to cover was why does it matter if the stroke is large vessel or small vessel? For few things, first of all, large vessel strokes, of course, are much bigger in size, meaning they usually have a much higher NIH stroke scale. In other words, they are more severe than small vessel disease. And because they are more severe and larger in size, they are associated with increased morbidity and even increased mortality compared to small vessel strokes. Morbidity meaning they are left with more deficits. Of course, the other difference is that large vessel strokes are amenable to endovascular intervention or mechanical thrombectomy, which small vessel disease strokes are not. And then large vessel strokes tend to produce a large amount of cerebral edema, which usually peaks between third to the fifth day. So, large vessel strokes need to be monitored in the hospital for a week or so. Not always, but most of them, at least for 3 to 5 days, because that's the time when cerebral edema is most likely to happen. And then cerebral edema is associated with increased morbidity and mortality if you don't treat it right away. They are also associated with increased risk of hemorrhagic conversion, which then again is associated with more deficits and increases risk of mortality. Of course, the larger the stroke, the higher the risk of reperfusion injury. And that is why the risk of hemorrhagic conversion is much, much more in large vessel strokes than in small vessel strokes. And I think that should be it. Does anyone have any questions about the basic management and classification of ischemic strokes?
Doesn't look like it, Doctor.
All right, sounds good. That should be it. Thank you very much.
Thank you.
Take care. Bye.